everyone. My name is April, and just before we start, I wanted to inform you that the WHO Western Pacific region, we are covering 38 countries and areas, and we have about 2.2 billion people living in this region. So that is, I think, slightly over about one-fourth of the whole entire world's population. So we have very diverse countries in our region, as you can see on the map here. We have all of the Pacific Island countries, but we also have China, Republic of Korea, Japan, Hong Kong is also part of our region, and Australia, New Zealand. So very, very diverse countries in our region. Um, so as you're very well aware, the Western Pacific region is actually aging very rapidly. So the projected time to transition from an aging society to an aged society, you can see on the top left, the top two bars in purple, Australia and New Zealand. So they've basically had about 63 and 64 years to go from an aging society to an aged society, whereas their countries, for example, like Korea, which only had 17 years for this transition. And then we have other countries like Brunei here, which has even shorter time, so 16 years, going from aging to an aged society. So as you can see on the bar graph, all of the countries globally are going to transition from aging to an aged society. Just a matter of how fast that transition is happening and when that transition is happening. So when we think about population aging, actually, that is very good news because that means that a lot of the sort of traditional public health efforts and investments, like vaccination and also maternal and child health, all those work, water and sanitation, another popular one, they've they've worked. So all this investment that we have made in public health, they have worked well. So hence we're seeing that people are living longer. But what we want to see is not just living longer, right? We want to live in good health. So there is still quite a bit of a gap between life expectancy and healthy life expectancy. So we want to close this gap as much as possible so that everybody can age in good health and enjoy the healthy life years. Okay. Sorry, give me one second. Oh, there we go. Okay, so this is the WHO definition of health. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. I believe many of you are familiar with this definition. Now, so traditionally, we have worked a lot on physical well-being. Then, in the last few decades, on mental well-being. And finally, we are beginning to talk about social well-being. So we're still in the early stages of trying to address and understand better social well-being. Now, um, we want to address the conditions that contribute to our health outcome. So the figure, the gingerbread man figure on the left is from Europe. So our European regional office, when they look at the adult European population and comparing between the poorest 20% and the richest, the most affluent 20%, the difference in health equity inequity experience between these two groups, the health services, the health sector, only explains 10% of this inequity. So all the other conditions outside of health, such as income security, social protection, living conditions, social and human capital, employment and working conditions, they explain the 90% of this inequity experienced by two different groups. Now, we try to do a very similar study in Philippines with data collected by area, which is under the ASEAN group. So when we looked at older adults, so in Philippines, older adults is 60 plus, we also see that healthcare explains only about 46.8%, then that means that the majority, so 50 and above percent, is explained by other conditions. So here 11.44% is explained by health behaviors, but still quite a large percentage is explained by conditions outside of the health sector. So what does that really mean then? So that means that most of the inequity sits outside of the health, the sort of the traditional health sector that we know of. So the response that means has to also sit outside of the clinics, hospitals, and healthcare centers. Right? So we essentially want to address the determinants of health. So that is what you see on the figure on the right. And I think many of you are probably very familiar with this figure. Okay, so then how does social prescribing come into play? Now, social prescribing, as we define it, is a means of connecting patients to a range of non-clinical services in the community to improve their health and well-being. So, instead of giving like a clinical, like a medical prescription, when a healthcare provider realizes or sees that actually this patient does not need any clinical prescription or could also benefit from uh, a non-clinical prescription, then the healthcare provider will make a referral to a link worker, and the link worker will able to prescribe social activity or something that addresses the root cause of the problem. So, if it could be something like a financial problem or housing problem or many other things that is actually contributing to a person's ill health. So that is social prescription. And most ideally, this happens at the community level and is followed up after back to the health sector, so health services. And as I mentioned, again, it could look, the social prescription could be in many different forms, such as getting support for financials or housing, or it could be lifelong learning to, reskill and physical well-being, maybe additional support with like diet and exercise, or if the person is not necessarily having some of this kind of social welfare challenge, but facing loneliness or depression or social isolation challenges, then they can be also prescribed to like artistic activities, arts engagement, could be referred to volunteer opportunities so that they can contribute to their society. And so these are just examples. And the key here is that it's really person-centered. So each person's social prescription is going to be very different. It's going to look very different, right? So again, this builds on evidence that addressing the determinants of health, such as socioeconomic status, social inclusion, housing, education, is key to improving the health outcomes. So, from our office, we have been working on adopting social prescribing as part of our healthy aging strategy. So, we are the first in all of WHO to do this. And very specifically, we are interested in social prescribing as one approach, so one way of realizing community-based integrated care. So in what we call community-based integrated care, we're taking a person-centered approach, so having the older person in the center, and making sure that health, social, and long-term care services are made available at the community level. And we think that social prescribing, with the support of link workers, can help to make this linkage, the integrated care, possible so that they can age in place. So this is included in the Regional Action Plan for Healthy Aging. And also we've developed a toolkit how to implement social prescribing, and we have a free online course that anyone can take on the WHO Academy course. And in 2024, we also designated the SingHealth Community Hospitals in Singapore as the first WHO collaborating center for social prescribing. Okay, so now I'm going to take you to Cambodia. So in Cambodia, so this was work that we did together with our Cambodia country office, WHO Cambodia country office, and the Royal University of Phnom Penh. And in Cambodia, this started during the COVID-19. And not we, sorry, the Royal University of Phnom Penh professors and our WHO country office in Cambodia, they were concerned about the mental health of people in Cambodia during the COVID-19 pandemic. So we were exploring how we can support the mental health of people during the days when we had physical distancing measures. So we trained the village health support groups. So these are people who are already living in the villages. So these are people living in the communities. There are community members, such as like village heads or women's association members, representatives. So these were the a little bit active community members. We've trained them to become link workers, and they and we did a study afterwards. So, in not all of the districts, but in select districts in Cambodia, we basically provided training to the village health support group members to become link workers to do social prescribing. And in our study, we had three groups. So each group, 400 sample size, the participants. And the first group, they lived in the villages with the village health support group who were trained to be link workers, and they received social prescribing. The group two, they lived in the same village. However, they did not receive social prescribing. And then the third group, they lived in villages where they did not have a link worker. So the village health support group members were not trained to do social prescribing. So we had the three groups, and it was a comparison like study. And we learned that with the group one, that received social prescribing, older adults, they found social prescribing to be helpful. Now, what did they find to be helpful? So, they liked the health education provided by the village health support group members, the link workers, and also they had a better understanding of the healthcare system. So, as you can imagine, this is a rural area in Cambodia. In our target population, because I'm coming from the healthy aging unit, our target population is older people. So older people often sometimes have difficulties filling out forms so that they can get the benefits from government. So the link workers, they supported with filling out forms for ID poor cards and also finding transportation to healthcare facilities. So these were some of the things that older people who receive social prescribing found most helpful. And there was also an increase, so about 27% increase in finding healthcare access in those who lived in the villages where they had trained link workers, and then for those who sorry, and then those who lived uh, in these villages, they also said that they were less likely to feel lonely. So less than 40 per, sorry, comparing to group two, those who did not receive social prescribing, those who received social prescribing, they reported less loneliness. Okay. So this is our study from Cambodia. Uh, and now I'm going to take you to Laos. So Lao PDR, which is another low middle income country in Southeast Asia. So this work is done by my colleague, and they also started this work during the COVID-19 pandemic. So they started the Connect program. So Connect stands for Community Network Engagement for Essential Healthcare and COVID-19 Responses Through Trust. So this was supported by the Ministry of Health and Ministry of Home Affairs, and also, of course, WHO. And this became a much bigger national program, I should say, not project, sorry. It had a national rollout, and it's still ongoing today. So, what is interesting about the Connect program is that they focused, as you can see on the top here, top left, they focused on building trust and improving health equity. And they really took the approach of community co-design. So it was led by the community members and the multi-sectoral collaboration. As you can see, not just Ministry of Health involved, but also with the Ministry of Home Affairs. They wanted to strengthen local governance, sorry, and initially, because this started during the COVID-19 pandemic, the focus was increasing the vaccination rate. But when they went out to the fields, they went out to meet the people and to the villages, they realized that, okay, these people are not going to want to take any vaccination unless their other problems are resolved first. So, meaning these other problems, problems that lie outside of the health sector. If I can give a brief example from the three villages. So it would look like having better access to funding for health services. So in this one village, they started like a merry-go-round kind of funding system where everybody chips in, and then you can one person will take turns to get that collected funding, and they can use it for like a transportation to a healthcare facility. So that was one example, taking care of transportation. And then the other example, which was quite impressive, is that they helped with addressing water access issue. So again, this is like rural Lao PDR. So please use your imagination a little bit. So in rural Lao PDR, not every household in the rural villages have access to water, clean water, right? So they help to negotiate with the sort of like this, how should I describe this? With this person who had access to this water pipe, and then they work with that person to negotiate among the village members so that more people could have running water at their homes. And they also supported with negotiating with the water company so that people who are in low socioeconomic status could have some deduction in their water bill. So again, not exactly health, but this is what they did so that they can finally talk about COVID-19 vaccination. And then the last example is so there was like a 93-year-old man who was unregistered in the sort of government system for health insurance claims. So they helped to register this person so that he could get the benefits that were available and provided by the government. So these are this could look like small things outside of the health sector, but they were all very helpful. They all built up and contributed to changing health behavior. So, some of the short-term outcomes from the Connect program. So, they not only build stronger community ownership for health, but it also had a 6.9-fold increase in the first dose of COVID-19 uptake. And And for antenatal care, those women were more likely to recommend health centers for antenatal care. This increased by 8.5 percentage points. And Also for facility delivery, so health center birth increased by 14 percent points from 27.2 to 41.5%. So among women exposed to Connect, delivery at the health center increased. So I do have to point out that the delivery at the hospital, however, did not increase, which I'm not entirely sure why. I have to ask my colleague more about that. Okay. And then now going back to social prescribing. So basically, I don't think I can, end this presentation without talking about AI. Now we are also looking into how can we use some of the AI into social prescribing. What are the things that we can use? So some of the very, very preliminary initial discussion is that maybe we can start with supporting with data collection and data cleaning because that takes up a lot of our time, right? When we do studies. And then we are also discussing how this AI powered ecosystem will look like and what are some of the data that we can connect so that we can have more personalized, customized social prescription for those who need this. And another other things are like growing the a regional learning hub. We're getting a lot of requests for social prescribing at our office, and it's a small team, our healthy aging unit. So we're trying to see how we can support our member states to introduce social prescribing. And then I talked about AI, and this has to be embedded, integrated into the primary healthcare system. We're not promoting social prescribing to be a standalone program. So we are building evidence. We're doing studies in different countries so that we can bring this to policymakers and so that it can be part of the PHC. So yeah, this brings me to the end of my presentation. We have a whole series in the Lancet Regional Health Western Pacific Journal on social prescribing. So if you're interested, do check it out, and you can see more of our work on our website. Thank you.